Next, we have Dr. Sergey Ginsburg. Dr. Ginsburg is a urologic oncologist specializing in laparoscopic and robotic surgery, focusing on genitourinary cancer care. He advocates for active surveillance and organ-sparing surgery whenever possible. Dr. Ginsburg is actively engaged in resident education, basic science, and clinical research. He has authored and co-authored many original research articles, book chapters, reviews, and instructional videos, and delivered numerous presentations at professional society meetings. Dr. Ginsburg?
Thank you very much for having me today. September is Prostate Cancer Awareness Month, and I'm glad we're able to recognize the importance of this disease. I'm going to echo some of the data that Dr. Kapoor has mentioned, and I also want to emphasize the progress that healthcare and urology specifically has made in the field of prostate cancer, and underline the importance that healthcare policy has and what impact, positive or negative, it may have on our patients. So this is from the National Cancer Center, and I want you to focus on the maroon line. Maroon line is prostate cancer specific mortality, and you can see two arrows there. The first arrow represents widely accepted interval of PSA testing, prostate cancer screening, basically. And you can see that that line drops dramatically over the next 2 decades, signifying the fact that prostate cancer mortality has improved. Now, can all of this be attributed to prostate cancer PSA screening? No. But a lot of literature supports at least 50 to 75% of that improvement, of that progress attributable to PSA screening. So PSA screening is critical, and recommending against it is really irresponsible, in my opinion. This graph demonstrates prostate cancer that presents in advanced or metastatic stage, so patients that potentially could have been caught earlier and prevented from advancing into this stage. So you could see, again, similar time frame in the late 80s, early 90s with adoption of PSA screening. The prostate cancer presenting with metastatic disease is extremely high, and then the rate more than halves. So it decreases significantly after introduction of PSA screening. Again, supporting our efforts and our progress in managing prostate cancer. Can all this be undone with recommendation against PSA screening? Not all of it, but most of it. So it's really important to reintroduce PSA screening or make it available to all men. So what did U.S. Services Preventive Task Force recommendation do? It introduced a lot of confusion. So what you see here is different recommendations by various professional societies with respect to PSA screening or prostate cancer screening. And none of these, with exception of the U.S. Preventive Services Task Force, recommends against screening. Everybody has their own kind of spin on PSA screening, and they vary in age at which the PSA screening starts, the interval between PSA screenings, etc. And there's new and developing smart and targeted screening, which is extremely high yield and mitigates some of the problems that U.S. Preventive Task Force flagged with PSA screening. But again, none of the professional societies, with exception of U.S. Preventive Task Force, recommends against screening. So just recognize that. People that are really close to the data and on day-to-day managing patients with prostate cancer do not believe that PSA screening should be outlawed. So what impact U.S. Preventive Task Force has had on the screening? Dramatic impact. So how does prostate cancer screening take place? It takes place in your primary care setting. Your family doctor gets a PSA test, and if it's abnormal, then they refer you to a urologist. So, the primary care setting is really the gatekeeper for PSA screening. And who was impacted the most by U.S. Preventive Task Force? It's the primary care doctors. Okay, so they are easily influenced by this information, and you can see from this graph that PSA screening in the primary care setting more than halved from when the U.S. Preventive Task Force recommendation against screening was introduced. Urologists, on the other hand, while they were perturbed by PSA by the recommendation, it did not impact them significantly. I think probably because we're closer to the data and we recognize the limitations of the recommendation. Harms of prostate cancer, these are the pillars on which U.S. Preventive Task Force based their recommendation, and really they can all be deconstructed. Risk of biopsy, yes, risk of biopsy is real, but with modern antibiotic prophylaxis and risk stratification so that not everybody gets prostate biopsy, I think we can mitigate that quite effectively. Overdiagnosis, I think we're a self-policing enterprise where we simply don't abuse this any longer. U.S. Preventive Task Force recommendation is based on practice patterns that are historic, the modern practice patterns, like Dr. Kapoor has mentioned, include active surveillance, and that active surveillance adoption approaches almost 50% of patients with low-grade non-aggressive prostate cancer. So that's really addressed adequately. It's our job as physicians to reassure and educate our patients to relieve their anxieties, and I think we can address that in an effective way. Over-treatment, again, we talked about active surveillance already, and patient education and patient decision-making needs, they need to be engaged in how they're treated, and they should not be denied that choice. By not screening them, we're denying them the choice of treatment. And, this is an important footprint on our healthcare expenditures. $13 billion annually spent on prostate cancer care. So we really need to emphasize the importance of this situation. Thank you again for having me. I'll answer any questions later.